Hello, my name is Yuri Dreo. I am the Chief Technical Officer at BrainTrip Limited, and in this lecture, I'll be giving you an introduction to the BDI test aimed at clinicians. In terms of disclosures, I've been involved in scientific research and development of the BDI test since 2019. I am employed and am receiving salary at BrainTrip. I also own stock at the company and am declaring a vested interest in the commercial application of the BDI test. This is a short presentation outline. First, we'll discuss the problem, which is why we might need another dementia test, even though it seems there's no shortage of them in current clinical practice. Secondly, we'll discuss what we refer to as barriers for EEG, which is an answer to the question of why there have been so few clinical applications of advanced methods of EEG analysis. And lastly, we'll discuss the BDI test itself, the science behind it, how it works, and how it was validated. This is a high level summary of the BDI test. The BDI test is an electrophysiological, so EEG based tool that helps to assess human cognitive status. It's non invasive, it's quick to perform, very simple to do, and it is designed to be a point of care test, meaning the BDI test was designed to be an ambulatory outpatient setting bedside kind of test. The BDI test is based on a highly replicated finding of EEG spectral changes in dementia. It measures the cognitive effects of neurodegeneration and not its etiology, which means that the BDI test is useful for different types of neurodegenerative dementias like Alzheimer's disease, frontotemporal dementia, vascular dementia, Lewy body dementia, and so on. The results of the BDI test are correlated with traditional psychological tests of cognition like the mini mental status exam, the MOCA, the ADAS, and so on. In a large validation trial, the BDI test attained high accuracy, a specificity of over 93%, and a sensitivity of over 84% at detecting early stage neurodegenerative dementia. And dementia is a hot topic in neurology nowadays. Why is that? Well, because of these things. And these things are antibodies targeted against the amyloid beta protein. Two of them, lecanemab and donanemab, have gained most attention, and that's primarily because these drugs have already been approved in the US as novel neuromodulatory treatments for Alzheimer's disease. And these treatments hopefully will gain approval from the European Medicines Agency this year in 2024. This will mark 22 years since the last approved treatment for Alzheimer's dementia in the European Union, which was memantine back in 2002. Hopefully, these two novel drugs will mark the end of something we could call the dementia treatment winter, which lasted for more than 20 years since 2002. And these novel treatments, the anti-amyloid proteins, have now opened what has been called the problem of early dementia detection. This is how it was described by Eisen and others in their publication in Nature Reviews of Neurology. And they said that the slowing of progression of Alzheimer's disease might be the greatest unmet medical need of our time. And that consensus is growing that for meaningful disease modification in Alzheimer's dementia, therapeutic intervention must be initiated at the very early, which means preclinical or even prodromal stages of this disease. The question now is, are most of the patients we diagnose with dementia eligible to receive these new treatments? Or in other words, are we diagnosing patients early enough so they are eligible for these new neuromodulatory treatments? An empirical answer to this question might be found in this study by Pradier and others, published in PLOS ONE. And this is a large study based on a French Alzheimer's disease register. They looked at over 500,000 patient records and analyzed 40,000 patients who had MMSE scores at the time of their dementia diagnosis. And they asked the very simple question of what is the average MMSE score of our patients at diagnosis of dementia? The answer was 18.9 points on the MMSE scale with a standard deviation of 5.5 points. This is a rather concerning figure, not an unexpected figure, but a concerning figure because 18.9 points on the MMSE scale is definitely not a patient with mild cognitive impairment, and it's definitely also not a patient at a preclinical or prodromal stage of the disease. This is the now famous trial by Van Dyke and others published in the New England Journal of Medicine on the novel neuromodulatory intervention of lecanemab in early Alzheimer's type dementia. They were measuring the changes on the clinical dementia rating scale, sum of boxes, and on this chart they were comparing the effect of this new treatment on the slowing down of cognitive deterioration in the two clinical arms, which is the placebo arm in blue and the lecanemab arm in orange. As we can see from this chart, there is a 30% decrease in the rate of progression of the lecanemab arm, demonstrating for the first time in over 2 decades that we have most likely a novel effective treatment for for Alzheimer's type dementia. But now we can ask the question of what kind of patients were receiving the lecanemab treatment in this arm of this trial. And the answer to this question is, of course, in the Van Dyke's paper. The average patient in the treatment arm had an MMSE score at the start of the trial of 25.5 points with a standard deviation of 2.2 points. Furthermore, no patient included in the lecanemab trial had an MMSE score of less than 22 points at the time of inclusion. This means that the typical patient in the lecanemab trial was, in terms of their cognitive function, quite a bit above the typical patient at the time of diagnosis at large, at least in the large French Alzheimer's register study by Pradier and others. So, as I said, the typical patient was not only quite above the typical patient at diagnosis of dementia, it was also well above the typical cutoff for cognitive impairment, which is about 24 MMSE points. This is concerning because this means basically that only a mere 30% of newly diagnosed patients are eligible for this new treatment just based on the severity of their cognitive symptoms alone. So this neglects the fact that they have to meet other criteria as well, such as age and amyloid positivity and so on, but merely on their cognitive deterioration. 30% of the patients included in this large Pradier and other study would not be eligible for would be eligible for this novel dementia treatment. And furthermore, a mere 10% of newly diagnosed dementia patients seem to be the typical candidates or the likely good responders. These are the ones above the 25.5 points on the MMSE scale. This is another chart from Pradier and others. As you recall, they calculated the average MMSE score at the time of diagnosis. In this chart, they broke down their patients into age ranges. And the purple curve shows the average MMSE score at diagnosis versus the age of the patients. And as we can see, the younger patients do tend to get diagnosed earlier, or better said, at a less deteriorated cognitive state. However, at no patient age does the average patient exceed the minimum MMSE cutoff used in the Van Dyke lecanemab treatment trial, which is the concerning statistics, meaning that that at no age range do we, on average, diagnose patients early enough to be eligible for these novel anti-dementia treatments. We can also take a look at this chart, which is taken from Jack and others' now famous paper on the dynamics of Alzheimer's pathological biomarkers, published in Lancet Neurology. We can see several biomarkers here. In red, the deposition of the amyloid beta protein; in dark blue, the tau-mediated neuronal injury; in green, structural changes in the brain, perhaps measurable with MRIs; in purple, the memory deterioration as measured on behavioral psychological tests of cognitive function; and in dark green, the overt clinical deterioration of the patient. And if we now, just for further illustration, put two markers on this chart, the first one, the lower purple circle, marks the average patient in the lecanemab trial at MMSE 25.5 points, which is well above the traditional cutoff for cognitive impairment. And the second upper purple circle is the average patient at the time of diagnosis, taken from the large Pradier cohort trial at an MMSE score of 18.9 points. There is a large gap between these two purple circles, and this gap is an illustration of the current clinical problem. In certain countries, the UK specifically, people are already taking note of this upcoming huge clinical issue. This is a news item published on the BBC, summarizing a report by Alzheimer's Research UK, which concluded that the National Health Service of the UK is simply not ready to disperse these new Alzheimer's drugs, the lecanemab and the donanemab, even when they get approved by the European Medicines Agency, simply because most patients do not get diagnosed early enough even to be eligible to receive this treatment. Another report published just a few weeks ago by Alzheimer's Society UK reaches a similar conclusion, and they determined that potentially hundreds of thousands of patients face being denied this new revolutionary dementia treatment in England simply because the methods currently used in clinical practice to confirm a dementia diagnosis, such as MRI scans and PET scans, simply aren't available enough, cheap enough, and scalable enough to be useful for early dementia detection. And this brings us to the actual problem at hand, which we illustrated in this slide. On the left side, we have a typical patient coming to perhaps a general physician, a family physician, or a specialist with some kind of cognitive issue. And this might be a subjective, self-reported cognitive issue. It might be an objectively determined cognitive issue, such as a lower than expected result on one of the cognitive screening tests. It might already be a diagnosis of mild cognitive impairment. This patient might have a family history of dementia, or it might just be a strongly expressed concern about the patient's cognitive status. It might be any of this. And clinicians get these kinds of patients every single day. And when they get them, they are faced with a difficult decision. And this decision is which of these patients that either claim to have cognitive impairments or indeed have mild cognitive impairments should then be sent to follow-up examinations, which are typically expensive and sometimes invasive. Exams like MRI scans, CAT scans, PET scans, lumbar punctures, analysis of cerebrospinal fluid proteins, which typically require referrals to radiology, neurology, psychiatry, detailed neuropsych exams, typically require clinical psychologists. So the question is, we obviously cannot refer every single patient reporting of cognitive issues to these exams, because that would, not to put too fine a point on it, simply break the budget. And furthermore, some of these tests having side effects are not clinically acceptable to just be given to the entire population. The side effects would outweigh their benefits. It is our firm belief that EEG technology is the perfect tool to fill this clinical decision gap. The clinical decision gap being, again, which patients should we refer for follow-up, confirmatory, detailed examinations. Why EEG? Why do we focus on EEG? Well, because EEG as a technology is perfectly positioned to make a huge positive impact on brain diagnostics. EEGs are typically about 100 times cheaper than the cheapest MRI scanner. They're also cheaper in terms of per test costs. And EEGs have the added advantage of nowadays being the size of credit cards, meaning that EEGs are mobile and they also offer millisecond precision in acquiring brain dynamics, which is essential when we're trying to evaluate fine functional abnormalities such as cognitive decline. Early cognitive decline will never be visible in a structural MRI scan. Secondly, we focus on EEGs because there is tremendous scientific interest in finding EEG biomarkers for common brain diseases. The chart on your right lists the number of peer-reviewed EEG publications in just the last 5 years published on a variety of common brain diseases and disorders like dementia, depression, anxiety, and so on. We can clearly see that there's a great deal of scientific work being done on the usefulness of EEG to detect, monitor, and in fact help guide the treatment of these common brain diseases and disorders. Every 5 years, we have hundreds, if not thousands, of new publications. And if we zoom in specifically on dementia and plot the number of peer-reviewed publications which involve EEG and the usefulness of EEG in dementia, we can see that the usefulness in EEG for dementia is supported by literally decades of research, with the number of peer-reviewed publications reaching about 5,000 last year. We have prepared a short summary of this vast and deep literature, which is accessible via the QR code on the right side of this slide. A more condensed version of and a summary of this vast literature can be attained from this consensus opinion paper on the usefulness of EEG in clinical dementia diagnosis. This consensus paper was published on the request of the International Federation for Clinical Neurophysiology. They assembled an expert panel, and the conclusions of this expert panel, published in the journal Clinical Neurophysiology by Rossini and others, were that the latest scientific findings suggest that EEG rhythm analysis is a valid screening tool to predict conversion to Alzheimer's type dementia, and that advanced analysis of EEG signals could represent a first-line screening tool, particularly because of EEG's high sensitivity to synaptic function, its non-invasiveness, its low cost, and its widespread availability. This is a very strong positive opinion on the usefulness of EEG in clinical dementia diagnostics. So if this is the case, if there's vast support in the scientific literature for the usefulness of EEG in early dementia detection, and if the expert consensus seems to be that this tool indeed should be used, why have there been so few clinical applications of EEG, not just for dementia, but broadly speaking? Well, our answer to this question has 4 parts. We call them barriers for broader EEG adoption. And these barriers can be broken down into hardware barriers. that consists of the fact that traditional clinical EEGs were actually quite expensive. They could reach up to hundreds of thousands of euros. They required dedicated special facilities, were definitely not portable. And to some degree, in our opinion, typical traditional clinical EEGs are overly specialized just for certain diseases. The prime example here is epilepsy. So the typical clinical EEGs nowadays in use are overly specialized for epilepsy, which means they're very good for epilepsy, but they might not be good for other diseases as well. And these traditional clinical EEGs were not very patient friendly. They were gel based and they required skin abrasion, which is unpleasant for most patients. Secondly, in terms of recording the EEG signals, this process typically, traditionally, required highly trained personnel, which needed long training times of months, if not years. This process was very manual, required a great deal of expertise and training, and it just was not scalable. Sending someone for an EEG recording typically required a referral, long wait times, and long wait times not just for the recording, but for the interpretation of the recording as well. This makes traditional EEG recordings not useful for the vast majority of brain diseases. Thirdly, the process of processing the raw EEG data, especially when it comes to calculating quantitative metrics from these signals, typically relied on specialist knowledge, either subspecialist MDs or PhD level researchers. It was very tedious, manual, required expensive, complex software, which again meant long wait times, again, not being scalable, not being useful in clinical practice as a point of care tool. And lastly, traditional EEG results had limited applicability because typically they rely on visual EEG interpretation alone. And only certain brain diseases, again, epilepsy is one of them, alter brainwave patterns to a sufficient degree that this is easily noticeable with naked eye visual inspection. But this doesn't apply to most other diseases, dementia, especially in its earliest stages, included. So even if one calculated, even if one relied not on visual inspection alone, but on quantitative markers of EEG, even then, most diseases are not detectable with a single or just a few EEG biomarkers. And apart from that, only experts could evaluate these EEG biomarkers. It was just not scalable, not easily interpretable. At BrainTrip, we spent about 6 years developing software that lets clinicians overcome three of these major barriers, which have so far prevented the widespread adoption of EEG to most brain diseases. The first barrier, the first obstacle, the hardware obstacle, has already been addressed by other companies. We are not an EEG hardware manufacturer. We actually purchase off-the-shelf EEGs, and our EEGs are not the typical EEGs you are used to in clinical practice. They're quite a bit more affordable. They're also portable. They're the size of credit cards, and these EEGs are therefore applicable to many other diseases, not just epilepsy. They also have the added advantage that EEG recordings with these EEGs do not require gel, they're gel free, and they also do not require skin abrasion, making these recordings quite a bit quicker and patient friendlier. These other barriers were, however, addressed by our software and are addressed by our software. The barrier of recording, processing, and the barrier of producing EEG results. Let's take a look at them one by one. Our software completely reinvents the process of EEG recording. The main feature of our EEG recording app is a machine-assisted EEG recorder that automatically interprets EEG data quality and instructs the user how to fix any issues likely to occur. This is what opens the doors to EEG recordings in most environments. This is what enables our tool to be a point of care, ambulatory, bedside, or outpatient test. This is what enables the BDI test to be done then and there when you see the patient, when you're examining them, or even, in fact, before. The main features of this EEG recording app is its short onboarding time. It requires a mere 5 hours of training to acquire the knowledge on how to record EEGs with our app. The app has a very intuitive graphical user interface with checklist functionality. Most personnel can be trained to do an EEG recording. This is not just limited to subspecialists or EEG specialists. Secondly, the act of processing the raw EEG data has also been completely automated with our software. We call this having a neuroscientist in the cloud at your disposal. We've built a state-of-the-art automatic pre-processing pipeline for EEG data that makes manual EEG pre-processing, cleaning, labeling obsolete. The main features of this app are its accuracy. Its performance is comparable or better than expert EEG reviewers at identifying and cleaning EEG artifacts. The pipeline is also completely automatic and it is fast. EEG analysis is performed in a matter of minutes. This is what enables the EEG results that are obtained with our system to be available in just a few minutes after recording. There is no wait time for our EEG results. Let's now switch gears and let's discuss the inner workings of the BDI test. As I mentioned in the beginning, the BDI test is based on quantitative metrics calculated from raw EEG signals. On the left side of the slide is a simplified flow chart of how the BDI test, how the data flows from beginning to end, how the BDI score is computed. We start with a raw EEG signal recorded within the app. This raw signal then gets pre-processed, it gets cleaned, its artifacts are either labeled and rejected or cleaned or corrected. The cleaned EEG signal is then subjected to spectral analysis using the Fourier transform. And on this spectrally altered EEG signal, do we then compute these EEG biomarkers? A great number of EEG biomarkers are computed, and all of them are then aggregated. They are combined into a final result, which is the BDI score. The BDI score, therefore, isn't one or two or three EEG biomarkers. It is, in fact, an agglomeration of several hundred quantitative parameters obtained from the EEG signal. On the right side of the slide is an illustration of this process starting from the raw EEG signal. Here you can see a raw EEG signal, 4 seconds of it on one of the parietal channels. The y-axis gives the amplitude in microvolts and the x-axis is the time in seconds. This raw EEG signal is then cleaned and analyzed spectrally to obtain the EEG spectrum at the bottom right of the slide. This EEG spectrum is a fairly typical EEG spectrum in human EEG data. Its most prominent feature is the alpha peak, which is observable at about 9 hertz. There is also a smaller peak in the beta range at about 17, 18 hertz. This is also typical for human EEG data. So the first step is now done. We have computed the EEG amplitude spectrum, and now we need to quantify features in this spectrum. We need to compute the so-called EEG biomarkers. And there are a multitude of biomarkers that we could compute, but the first thing we usually do is focus on one particular spectral band, one type of brain waves. For example, this might be the alpha band. The alpha band is between 8 and 12 hertz, marked on the chart below. In this alpha band, one of the easiest biomarkers to quantify is the previously mentioned peak is the spectral peak in the alpha band. In this case, the peak frequency of the alpha band stands at 9.25 hertz. This is particular to this subject and this channel of EEG data. In a different subject, or in fact in a different channel on this subject, the peak frequency might be slightly different, might be 9 hertz or 10 hertz or something along these lines. The peak frequency is, of course, not the only biomarker we could compute. Another one might be the average frequency, which is not simply the peak of the spectral distribution, but is the weighted average of all frequencies in the alpha band weighted by their spectral power. In this case, the average frequency stands at 9.44 hertz. Another biomarker we could quantify is the area under the curve, under the spectral curve, which equals the band power, the power of a particular EEG oscillation. In this case, the power of the alpha band stands at 154 microvolts squared. Another potential biomarker might be attained by selecting another frequency band, the theta band, which lies between 4 and 8 hertz. And we could now compute the ratio of powers between the alpha, the green part, and the theta, the purple part bands. In this case, the ratio of alpha to theta power stands at about 11, which means there's about 11 times more power in the alpha band than the theta band. These biomarkers, these 4 biomarkers that I mentioned, are thoroughly described in the scientific literature. They are very commonly used to analyze EEG data, especially when it comes to dementia. Typically, in dementia, we can observe the decrease in the peak alpha frequency, which goes from, let's say, 9 or 10 hertz to 8 or 7 or even 6 hertz with the progression of neurodegeneration. Furthermore, in dementia, we also see a shift in power from the alpha band to the theta band, meaning that this power ratio slowly goes down. Randomly selected example of just one of these multitude of scientific papers on this phenomenon is taken from Choi and others. Their paper was published in Nature Scientific Reports, and this is one of the charts they produced. You can see 3 plots here. They pertain to 3 different biomarkers obtained from EEG signals. The left plot is the median frequency, which is something similar to the average frequency we discussed previously. The middle chart is the peak frequency, and the right chart gives the alpha to theta power ratio, which we also discussed. On each of these plots, on the x-axis, you can see the value of this biomarker, and on the y-axis, you can see the mini mental status exam score obtained with one patient. So each of these dots on each of the plots is one patient, and the value of their EEG biomarker is on the x-axis and their cognitive status is on the y-axis. Let's focus on this middle plot, on the peak frequency plot, which we discussed most thoroughly. And let's take a look at a patient represented by a red dot at a peak alpha frequency of about 9 hertz, which is something similar to what we discussed earlier. And this patient, as you can see, has a MMSE score of about 14. There is a strongly statistically significant correlation between each of these parameters and the cognitive status of the patients. The p-values for these correlations range from 10 to the minus 8 to 10 to the minus 24th. So extremely highly statistically significant results. So these parameters are predictors of cognitive status. But as these scatter plots also clearly show, they are not very accurate predictors of cognitive status. Because as we discussed, this one patient with a peak alpha frequency of 9 and an MMSE score of 14, we can find a multitude of other patients with the same peak alpha frequency of 9 hertz and MMSE scores ranging anywhere from 14 to 30. So from cognitively completely unaffected to cognitively highly affected. Uh, this means that while these parameters can predict cognitive status, they cannot predict it accurately in isolation. And this is why, to make an accurate prediction of cognitive status from EEG data, one needs to take into account not just a single biomarker like peak alpha frequency or 2 or even 3 biomarkers, but tens, if not hundreds of biomarkers. If one does that, if you combine hundreds of such quantitative EEG parameters, then the accuracy on the individual level goes up significantly. In fact, we have calculated several 100 million potential EEG biomarkers and assessed them as a means of predicting patients' cognitive status. Our biomarkers are divided based on type. We already discussed this. We have biomarkers of peak frequency, average frequency, band power, and power ratio. But then biomarkers can also be divided based on condition, eyes open or eyes closed. Based on the statistic we compute on them, is this an average value of the biomarker or its standard deviation? We have to, of course, choose a spectral band. We also discussed this. And of course, each biomarker can be calculated on one or several EEG channels. In our EEG system, we use 24 channels spread across the scalp in a standard 10-20 position scheme. But then we are left with potentially hundreds of millions of potential EEG biomarkers. And the first thing we need to do is sift through this multitude of EEG biomarkers and select those that are most predictive of patients' cognitive status. And this is done by the third part of our software, which is a powerful inference engine for automatic EEG data evaluation. This inference engine scans through these hundreds of millions of potential biomarkers and finds those that are most predictive for a given disease state. Typically, several hundred biomarkers are identified, corrected for confounders, so variables which might affect EEG data apart from the patient having a disease, and then combined with machine learning into a single metric. So here we have the evaluation of this process. In terms of dementia, we have isolated a few hundred quantitative EEG parameters, and these then get aggregated using machine learning into a single metric, which we call the BDI score. The BDI score ranges from 0 to 100 points. And in this validation trial on more than 400 human participants, we have measured its high accuracy in predicting cognitive impairment. The BDI score attained a specificity of 93%, a sensitivity of 84%, and an overall accuracy of 92% at detecting early stage cognitive impairment, severe enough to be labeled as likely dementia. The chart on your right shows the distribution of BDI scores in the two arms of this validation trial. The red population, the red arm, are the participants who scored very low on several tests of cognitive function, in fact, so low that they might be labeled as probable dementia. The participants in the blue distribution scored highly on several tests of cognitive function, so high that they can be typically labeled as cognitively normal. And as we can clearly see, the BDI scores on the x-axis neatly separate these two populations, which gives the BDI score, as I said, its high specificity and sensitivity. Additionally, as mentioned, the BDI system also corrects for 6 common confounding variables, which also affect EEG data. And these variables are age, sex, years of education, handedness, head size, and time of EEG recording. These variables are entered into the BDI app at the time of recording and automatically corrected for. This is what the BDI test looks in practice. Everything you need to conduct the test is on the picture on the left. There is a cap with sponges in it, which are soaked in saline solution. The EEG cap does not use gel, and there's no skin abrasion in this process. You cannot see the mobile EEG amplifier, which is the size of a credit card and is attached to the back of the cap. This amplifier records the EEG data and connects wirelessly to a tablet computer, which you see on the lower right corner of the picture. The BDI test is a CE marked medical device with a with a stated purpose of to be used as a screening test for early dementia detection. It can be done very quickly, start to finish in 30 minutes, of which 8 minutes are the EEG recording itself. Everything else is cap preparation and waiting for the results. In fact, the results themselves take a mere 5 to 10 minutes to compute. This time is included in the 30 minutes test time. The test itself is fully automatic, and it requires a mere 5 hours of training to perform adequately. Let's now turn back to this slide, the so-called dementia diagnostic dilemma that we spoke about. And in this slide, we can again see the issue, a patient with some kind of cognitive issue, and then expensive invasive follow-up testing. We firmly believe that the BDI test is a good tool that can help clinicians bridge this decision gap of which patients are the good candidates, are the better candidates for more expensive, more invasive follow-up testing in cases of suspected neurodegenerative dementias. One last point, since we are discussing gaps, the BDI test, being an EEG-based test, also bridges a different gap, and that is the gap between the molecular and behavioral level of cognition. And this is a unique and powerful feature of EEG signals. Here we can see several different types of dementia, neurodegenerative dementia, Alzheimer's disease, Lewy body dementia, Creutzfeldt-Jacobs disease. And these diseases have different molecular underpinnings, different molecular etiologies, which all converge on the pathway of neuronal death, synaptic dysfunction, which then leads to large-scale organ degeneration and, in fact, later cognitive symptoms of dementia. The tests currently clinically available are in the gray on the right side. And as we can see, these tests typically have a fairly narrow range of scales that they can tap and assess. MRIs can only assess macroscopic tissue degeneration. Psychological tests can only assess the behavioral level. And tests of cerebrospinal fluid proteins can only assess the molecular level. But the BDI test, because precisely it relies on quantitative analysis of EEG signals, and EEG signals being generated by postsynaptic currents, so cellular events, while at the same time being dependent on large-scale organ-level synchrony in tissue, because this large-scale organ-level synchrony in brain tissue is what underpins cognitive function. This is why the BDI test, in fact, EEG signals themselves can help clinicians bridge this large gap between the molecular level and the behavioral level of cognitive function. And this is a unique and powerful feature of EEG signal that should definitely be clinically tapped. As a list of potential applications, of course, the BDI test may be used as a clinical screening tool for dementia at the primary care level. It can be used as the specialist care level as an additional objective biomarker of cognitive status. One can use it as a decision support tool before ordering more expensive, invasive follow up testing. One can use it even as a patient level monitor of treatment efficacy. One can use it to monitor disease progression because the BDI test is, in fact, infinitely repeatable. This is its greatest strength compared to traditional behavioral cognitive testing, because those tests definitely have learning effects. The BDI test doesn't. It can be potentially used for drug discovery to validate the positive cognitive effects of novel drugs on patients and for clinical trial design. As a summary, again, the BDI test is an electrophysiological tool for assessing cognitive status. It's non-invasive, cost-effective, quick, and easy to perform. It helps clinicians to objectively establish cognitive decline due to likely neurodegeneration ahead of further testing. It's based on a highly replicated finding of EEG spectral changes in dementia. The BDI test is specific for the cognitive effects of dementia and not its etiology. This is its greatest strength. This is why the BDI test can be used for different types of neurodegenerative dementia. So it doesn't perform a differential diagnosis, but it effectively separates pseudo-dementias from neurodegenerative dementias. It can be used to track cognitive decline longitudinally, and in fact, its score is correlated with traditional psychological measures of cognition. Thank you for your attention. I'd like to conclude with this quote from Paul L. Nunes, the author of one of the most famous books on quantitative analysis of EEG signals. And he concluded his book that EEG is a proverbial window on the human mind. And to this, we would just like to add that it's about time we opened this window in clinical practice. Thank you.